Good afternoon. Thank you so much for joining us in our first ever live webinar. The topic today is going to be understanding anaphylaxis and trying to get everyone prepared in the event that this may happen to you or to someone you love. I am Dr. Emily Langley. I am a board certified allergist immunologist at Carolina Asthma and Allergy Center. There will be questions, Q&A at the end, so feel free to add any questions along the way in the comment section. We have also received some comments prior to the webinar that we will also be sorting through and answering at the end. So feel free to leave comments in the box and we'll try to get to as many as we can at the end. So let's start with the definition of anaphylaxis. I think this will help to frame our topic today. The most well-defined definition is that anaphylaxis is an acute, life-threatening, systemic allergic reaction that may have a wide range of clinical manifestations. I definitely want to break this down because there's some really key terms in this definition. First, it is acute. For us as physicians, the word acute means it happens fast. It's an immediate onset reaction. It can happen as soon as 5 minutes or as long out potentially as 2 hours in most cases. It is very, very rare to have a delayed episode of anaphylaxis that's hours or days from an allergen. Second, it is life-threatening. There can be severe symptoms that can occur with anaphylaxis, and it can lead to a very severe condition called anaphylactic shock. So it's very important to act quickly and recognize the signs and symptoms, and we will be going through some of those topics today. Third, it's a systemic allergic reaction. So this means that multiple organ systems are involved in the reaction, and it's not just a hive or just one manifestation of an allergic reaction. And then lastly, wide range of clinical manifestations of which we will go through in more detail so that you can be prepared to recognize the signs and the symptoms. So the most widely accepted definition, while there are a few out there in the medical literature, is when there are 2 or more organ systems affected after an allergen is likely been exposed to. So we will kind of go through each of those organ systems that can be involved and what that looks like. In 90% of cases, the skin or the cutaneous organ system is involved in an allergic reaction. This can manifest as hives, which are itchy, kind of whelp-like skin reactions, just diffuse itching in the hands or the feet, scalp, anywhere on the body. Flushing, which is a warmth sensation, typically on the face or the neck, or angioedema, which is swelling of soft tissues. That can occur eyelids, lips, hands, or really anywhere on the body. However, it is important to recognize that in rapidly progressive anaphylaxis, there may not be the first sign, which is the skin reactions. So we definitely have to be monitoring for other signs and symptoms of anaphylaxis. I'll point out on this slide, the first picture on the left is kind of diffuse urticaria or hives. So as you can see, they're red, raised. Typically, they're going to be very itchy for the person experiencing them. And in the picture on the right, that is a little boy who is experiencing upper lip angioedema or swelling, and then is also having several urticarial lesions on his neck and his chest. Respiratory symptoms are the second most common manifestation of an allergic reaction, and they can be present in up to 70% of cases. And when we think of respiratory, we also want to recognize that it could be upper airway or lower airway. So the upper airway, you could see kind of the acute onset of nasal congestion. The nose could be runny. The eyes could be watery or itchy. You could have hoarseness of the voice. And then following that, lower airway symptoms, cough, wheezing, shortness of breath, or the feeling that the throat is getting tight, the voice is changing, or the child or adult is making a sound that would indicate upper airway congestion called stridor. Gastrointestinal symptoms are also very common and can be present in almost half of patients. These can range from just a feeling of abdominal cramping or pain to full-blown nausea, vomiting, or diarrhea. The last symptom that can be involved in anaphylaxis is cardiovascular. This is present in 40 to 45% of cases, and this would indicate that you're potentially going from anaphylaxis to anaphylactic shock. Patients can lose blood pressure very quickly, which can lead to dizziness, lightheadedness, even loss of consciousness called syncope. And then they can also have an increase in their heart rate, a feeling of heart palpitations, or even a feeling of anxiety or something we call impending doom due to the severity of the reaction. So how common is this? I think people talk about it a lot, but how often do we see it? Lifetime prevalence of anaphylaxis is widely unknown. However, it is estimated to be about 2 to 5% from all different causes. There are several risk factors that can predispose a patient to more severe anaphylaxis. Those would be patients that already have coexisting asthma, especially asthma that is poorly controlled, cardiovascular disease, such as coronary heart disease or other heart arrhythmias that are on multiple medications for those, and older age can be a risk factor for more severe cases. The three leading causes in the United States of anaphylaxis are food-induced, venom-induced, and medication-induced. So anaphylaxis that leads to death is a very rare occurrence, fortunately, but it is on the rise in Western countries. There are approximately 150 fatalities each year from food-induced anaphylaxis. And the majority of those come from allergens to peanuts or to tree nuts. So that would be cashews, pecans, walnuts, pistachios, and then of course peanuts, which are a legume. Medications can also cause fatal events through anaphylactic reactions. It is approximated somewhere around 500 deaths per year. Lastly, venom-induced anaphylaxis, so that is stinging insect or fire ant anaphylaxis, results in somewhere between 50 and 100 deaths per year. However, that statistic may be underrepresented or underestimated due to sometimes unknown deaths. The overall mortality of anaphylaxis is approximately 1 to 2 deaths per 1 million people, again, potentially underestimated and attributed to other causes of death. So how many different things can cause anaphylaxis? Actually, lots of different things can cause anaphylaxis. We have talked about the three most common, which are foods, medications, and venoms. The most common foods that cause anaphylaxis are peanut, tree nuts, milk, egg, wheat, fish, shellfish, and sesame. Those comprise the top 9 allergens. Medications, antibiotics are unfortunately one of the top leading causes of anaphylaxis, and it may be an antibiotic that's been taken and tolerated multiple times in the past. NSAIDs, such as ibuprofen, naproxen, can cause anaphylaxis. And then a new class of drugs called biologics are increasingly causing anaphylaxis and are typically given in a physician office for this reason, at least with the first through the third doses. Venoms, including all types of stinging insects, honeybees, wasps, hornets, and yellow jackets, as well as fire ants. Latex is a common cause of anaphylaxis, but fortunately is on the decrease just because latex is not used in hospital and healthcare settings as often as it was in the past. Allergy shots can cause anaphylaxis, and we try to educate our patients on signs and symptoms if they are on a treatment, whether it's venom or environmental allergy shots. Vaccines can cause allergic reactions. Hormones, specifically progesterone, some women do suffer from a condition called progesterone hypersensitivity. Exercise is an interesting cause of anaphylaxis, often with what we call a cofactor, where you either eat a food or take a medication and then exercise, which can lead to an anaphylactic reaction. There's an emerging mammalian meat allergy that is actually caused by a tick bite called alpha-gal. That is an exception to the acute onset of allergic reactions and can be delayed in nature as far as 4 to 8 hours after ingestion of mammalian meat. People with cold-induced urticaria can experience anaphylaxis, especially if they jump into a cold pool or have a very severe cold exposure that can lead to a multi-organ system reaction. And lastly, there is idiopathic anaphylaxis, which means people have manifestations of a severe allergic reaction with no known cause. So let's dive into food allergy just a little bit more. It is the leading cause of ED visits in the United States for allergic reactions. As we've discussed, nuts are the most common, followed by milk and then fish and shellfish. Patients that are the most highest risk for ED visits associated with their food allergies would be adolescents, typically males, patients with asthma, especially those with poorly controlled asthma, or those that did not receive epinephrine or the epinephrine treatment was delayed, resulting in a more serious and potentially fatal anaphylactic reaction. Venom allergy affects approximately 0.5 to 3% of the US population. There are 5 Hymenoptera species that can cause people to have an allergic reaction. These would be stings from honeybees, wasps, white-faced hornets, yellow hornets, and yellow jackets, as well as 2 types of fire ants, one that appears red and one that appears black. High-risk patients for venom anaphylaxis would be older males, typically those that are on cardiovascular medications like beta blockers. So moving on to treatment of anaphylaxis. So in the 1970s, the epinephrine autoinjector was invented, and then it received FDA approval in 1987. The most standard kind of household name for an autoinjector is called EpiPen. However, over the last several decades, multiple other drug companies have developed other autoinjectors. Mylan produces a EpiPen generic, acts just like an EpiPen. There are multiple other generics, including Adrenaclix. Teva makes a generic. And then also Auvi-Q is a great option. It's a smaller cartridge type self-injector that actually gives you an audio of directions to help patients use the device correctly. The Epi autoinjectors come in 3 different doses. Auvi-Q would be the only manufacturer that makes an infant dose. This is a 0.1 milligram. It also has a shorter needle length for the size of the infant's leg. It looks like this, kind of purple gray, but it is used exactly like the other doses of Auvi-Q. The other more well-established EpiPen autoinjectors or generics are going to come in standard doses of 0.15 milligrams for the children or the junior version, or 0.3 milligram for what's called the adult or adolescent version. It is important to note that self-injectable epinephrine is dosed based on weight. It has nothing to do with age. So the junior dose would be for patients between 33 and 66 pounds, and the quote adult dose would be for patients greater than 66 pounds. What I like to tell my patients is every time that their epinephrine is renewed, it is really important to pull up the box, check the expiration date, and also open the box, because what we may prescribe for you may not be exactly what you pick up at your pharmacy unless it is specifically an AVIQ. So it's important to orient yourself to the device because there may be a change in exactly how you may use the device. Some boxes of self-injectable epi are going to come with a trainer, some are not, but I'm sure there's videos or your allergist or provider can help you learn to use the device if it looks a little different than what you are used to. In August of 2024, the FDA approved a different type of epinephrine, which is given by inhalation. The name of this device is Neffy. You can see in the pictures, it's a very small handheld device, kind of resembles Narcan or another form of an inhaled medication. There are 2 doses available now. There's a 1 milligram for patients weighing 15 kilos to 30 kilos, or approximately 33 to 66 pounds. And there's a 2 milligram dose for patients weighing over 66 pounds. It typically comes in a 2-pack. You can keep it in a nice little convenient carrying case, and it is available at most retail pharmacies. So one of the biggest questions we get in clinical practice is, when do I use the EpiPen? So the simple answer is when there are 2 or more organ systems involved in the reaction, or if one organ system is severe, i.e. respiratory, GI, or if there's cardiovascular compromise. The more real-world answer in my mind is, if you think you need to use it, you do. The way to use it is you inject it into the outer thigh muscle, preferably with the clothing off. If that is not possible due to the emergent need for the epi, it can go through thin clothing. If it's denim or thick sweatpants, it is best to try to pull down the clothing and get immediately to the skin. A second dose can be used if symptoms are not improving in the patient in 3 to 5 minutes. Obviously, at that point, help is hopefully on the way, but if there is a delay of EMS or getting to an emergency room, a second dose is recommended. The reason to go to the emergency room is not because you've given a medication that could be harmful to your heart or your skin or your respiratory system. The reason we recommend to go to the ER is that a patient is experiencing a severe allergic reaction. Other interventions may be needed, such as IV fluids, oxygen, in rare cases, intubation. So it's important that you are being monitored by an emergency room physician at the time in order to observe, potentially for a delayed reaction as well. So that's the recommendation still, is to go to an emergency room. I cannot stress again, epi early, epi fast. Delay in epinephrine can result in a more severe reaction. If you have an allergist or a provider that helps you with your allergies, you may have seen what's called an anaphylaxis action plan. This is a great pictorial diagram of different symptoms that could develop during anaphylaxis and how to treat them. It includes the patient's name, their weight, whether they have asthma or not, exactly what their allergens are, if known. And then it also lists the medications that should be available to that patient in case of a reaction, including antihistamines, whether it's Benadryl, Zyrtec, or another antihistamine, and what epinephrine device they have and how it should be used. These are often used in schools, daycares, or just in the home setting as reference. So how can you prevent this from happening? Obviously, no one wants this to happen to them or to a loved one. So the first thing is to know your allergen. So that's where an allergist comes into play, is helping to identify what the food allergen was, what the venom allergy is, or the medication. So staying vigilant as to the signs and symptoms of an allergic reaction is also very important. If there's been a possible cross-contamination or exposure, it is important to observe the patient for at least 2 hours after the exposure. Some signs and symptoms of an allergic reaction can be subtle. For example, a child that cannot speak may become very sleepy. They may become very irritable. They may act like their stomach hurts. They may start to have increased work of breathing. So the signs can certainly overlap with other conditions. So it's important to continue to stay vigilant and monitor closely. If the reaction is started, the recommendation is to initiate the anaphylaxis action plan and go forward with injection of epinephrine if there are moderate to severe symptoms present. There are also treatment options available to reduce the risk of anaphylaxis if the allergen is known. For example, with foods, there are 2 immunotherapy options now available. One is called oral immunotherapy, and it is offered for various foods, including peanuts, tree nuts, sesame, and egg. There's also sublingual immunotherapy, and lastly, Xolair, which is an injection that can reduce the risk of anaphylaxis through its mechanism as an anti-IgE antibody. For patients with venom allergy, venom immunotherapy can be an effective way to reduce their risk for subsequent stings or bites that could result in subsequent allergic reactions. That is all I have for the slides. We're going to open it up to questions, and I will look forward to answering some of those. Okay, the first question that we received is, have there been positive results for people using Neffy? So this is a really great question, and believe me, physicians also had this question when Neffy was approved by the FDA in August. As I mentioned, this self-injectable epinephrine device has been available since 1980. So that's been the gold standard of treatment for the last 40 to 45 years. We were all very excited for it to come out. However, as you can imagine, the studies were done in healthy subjects, not subjects currently experiencing an allergic reaction. However, in December of this past year, 2025, the Annals of Allergy, Asthma, and Immunology published a more real-world comment or paper about use of Neffy in certain situations. They concluded it was 545 patients who had experienced anaphylaxis, typically in a doctor's office, either from allergy shots or from during food oral challenges. And the results of that did show that they were successfully treated, their anaphylaxis abated with a single dose of Neffy in about 88.9% of patients, so approximately 9 out of 10. This is very consistent with what has been seen with single dose epinephrine into intramuscular, which is approximately 89.2. So it is showing positive results. I think we'll continue to see more and more papers published as it is used in real world settings. But I think it is a great tool for patients who have venom or food allergies to carry in their anaphylaxis kit. So our next question is, for kids before giving EpiPen for a more minor reaction, is Benadryl or Zyrtec more recommended now? Yeah, so this has come up in the last couple of years. The main reason for kind of an opinion change is that Benadryl is a sedating antihistamine. So especially in young children or older adults, they can become very sleepy from using Benadryl. And at that point, it can be very hard to distinguish whether that sleepiness is from the allergic reaction itself or is it a medication side effect. So there are a lot of allergists and providers that are now recommending using Zyrtec as the antihistamine of choice for minor reactions rather than Benadryl. I will say, however, Benadryl still has a quicker onset of action, approximately 15 to 30 minutes, whereas Zyrtec can take somewhere between 20 and 60 minutes for onset of action. So we are still using Benadryl in the clinical setting for allergic reactions due to its quick onset of action, but do want to educate patients that it can cause some drowsiness in specific people. Our third question is, how concerned should we be about anaphylaxis if we are on a maintenance dose of venom therapy? Okay, that's another really great but hard question to answer. Unfortunately, there is no simple way to determine the effectiveness of protection from a future sting. However, studies would show patients that have been on maintenance dosing of venom immunotherapy at least 3 years, if not 5 years, would have a reduction down to somewhere 2 to 3% of an 2 to 3% reduction in anaphylaxis from a subsequent sting. So it can depend on exactly where you are in your maintenance phase of venom immunotherapy. The one thing to know that in your maintenance, most people are receiving approximately the equivalent of 2 stings per insect they're being desensitized to. So that can certainly be some reassurance if you have a subsequent sting and you are on maintenance immunotherapy. Is it common for people with chronic hives to get anaphylaxis? I would say the short answer to that is it is not common. It is rare for a patient with chronic urticaria or chronic angioedema to have a multi-system allergic reaction. However, there are very many exceptions to that. For example, if they also suffer from any type of mast cell disorder or idiopathic anaphylaxis disorder, obviously they are going to be at higher risk for a multi-system reaction. However, patients that suffer from traditional chronic spontaneous urticaria or CSU rarely have a multi-organ system reaction. What are the main distinctions between a major asthma attack and anaphylaxis? So an asthma attack is going to be a pure respiratory reaction. It can present obviously with an acute onset, cough, wheezing, shortness of breath, chest tightness, palpitations. So it's going to be localized just to that respiratory tract. It can be hard to distinguish in a patient that's having an anaphylactic reaction and their anaphylaxis is respiratory primarily. So if they're not having other cutaneous reactions, it can be difficult. But I think that's where the clinical setting comes in. If there's been a possible exposure to an allergen, then you would kind of want to err on the side of treatment for anaphylaxis. If it's in a patient that is a known asthmatic and there hasn't been a known allergen, then I would probably treat more towards the asthma exacerbation. Are EpiPens still effective after the expiration date? How strict is the expiration date? Great question. We get this all the time because they can be expensive. It's hard to renew them year after year. So they actually did, it's a pretty old study now. I can't quote exactly where it's from. I'd have to look that up. But they looked at 2-year-old EpiPens. These would be pens that had been kept temperature sensitive, meaning they weren't kept in a hot car or frozen. And they concluded that 80% of the dose was available or effective even at the 2-year mark. So my advice is always to have an up-to-date EpiPen that's the one that you're always, that's always available, and to have some backups. If they're 6 months old, it's much better to use a 6-month-old EpiPen than to not have Epi at all. But it is important to try to have that up-to-date EpiPen as the one that you are using more often or carrying most often. What are the steps that one should take if they go into anaphylaxis by themselves? So I think the first thing for this is kind of going through those, like, ABCs. I think number one is take a deep breath and don't panic. Number two is to call for help. So whether that is calling a neighbor to come over, if that's calling a friend that's nearby or a family member, or just going ahead and calling 911. If you are outside when this is happening and it is hot, or you are sweaty or exercising, you need to stop. You need to get your heart rate down, get inside to a cooler environment, and then we would recommend that you lay back. Don't continue to stand, run, or walk, because that can cause a reduction in your blood pressure and you can have fainting or a syncopal response. Then we would recommend, if you're laying down, going ahead and locating your EpiPen, using your EpiPen, self-injectable epinephrine, and then having another pen available in case you are not improving in 3 to 5 minutes. If epinephrine has been administered and 911 has been called, but waiting on ambulance, is there a certain position the person should sit or lay in to help them? Yeah, I think that's a little similar to the last question. But again, it is important to lay down. That way, blood is not pooling in your legs, and you are potentially lifting the legs up to create blood flow to the brain and the heart. You want to not stand, walk, or run. If the person is having difficulty breathing and they feel better sitting, kind of in more of a tripod position, that would also be safe to sit with legs extended and kind of tripoding to help them get better airflow. Again, cool environments are also better than hot environments because that results in kind of what's called a vasodilatory response. What will happen if you give epi in a panic but didn't need it? The short answer is you will have an increased heart rate. You may feel some anxiety or palpitations, but nothing more than that is likely going to happen as long as you are young and healthy. So that is why we say epi early, epi fast, because we'd rather go ahead and give the EpiPen, even if maybe it was a milder reaction than needed, because the risk of not giving it much outweighs giving it in a setting that it maybe is not needed. Now, we have had parents accidentally give themselves epi when they were trying to give it to the child. If it is given in an extremity, such as the thumb or the finger, we do recommend that you are seen, just because it could have hit the bone or caused some other type of damage. But in general, giving epi in a panic is much better than not giving epi at all. Does Neffy have the same temperature restrictions as EpiPens? I do believe they recommend storage at room temperature. I would actually have to pull up the PI. I think it's a little bit more lenient in terms of temperature, but again, epi is a very sensitive medication to both light and heat. So you do not want to keep these in a car, a glove compartment, or somewhere that can get overheated. Also, epi should not be frozen. So while you might want to keep it in a cooler, if you're in a hot environment, you do not want the medication to be frozen. We are going to conclude here. If you have further questions, please reach out. Please make an appointment. On behalf of all the allergists and providers at Carolina Asthma and Allergy, this is our passion, and we love to help patients with any type of allergic disorder, especially those that can produce anaphylaxis. So thank you so much again for your time, and we look forward to seeing you soon.